we're going to focus a little bit on the role of the staff nurse in antimicrobial stewardship. And it may be a little bit different in critical access hospitals, but I think most of the things that are in the research really will apply to you. Next slide. So I think you all know that the nurse's perspective and active engagement, that's really going to be central to the success of your antimicrobial stewardship program. We've gotten a little bit stuck over time with this is the pharmacist running this. And I totally agree with that concept, because if you don't have your pharmacist on board, your program's probably not going to be successful in a critical access hospital where you don't have access to an infection preventionist. But that nurse is really key, because they're the front line. They're the ones that are going to be working with the physicians directly most of the time. You may only have your pharmacist during the day, not for 24 hours a day, 7 days a week. And then your staff nurses, they really are going to play a really key role in addressing antibiotic resistance. If they're not participating in your program, it's probably not going to be as effective. They make the critical decisions regarding the safe antibiotic administration and monitoring processes and practices. They can be key to that. And Dr. Stenyan, do you have anything you want to add there?
Yeah, this is, I mean, I think such a evolving kind of role for the staff nurse and stewardship. And, you know, I think if they have a role to play, it's in smaller facilities and they know the patients, they see the patients, they know the physicians. And this is definitely an area that they can be actively engaged in.
Okay, thank you.
Mm-hmm.
And Jessica, welcome. We saw you join. Next slide. So remember, they're the ones that share the they have the responsibility for actually administering those antibiotics. And very often they're going to be the last professional that's going to evaluate the appropriateness of that prescribed medication before it's administered. They're your key assets. Next slide. So in the literature, there are 5 key ways that nurses influence antimicrobial stewardship programs. And these are the things that you can ask your nurses to participate in. And, you know, feel free to chime in if you see other areas where they could be helping. And Dr. Stenyan, please chime in too.
Will do.
Okay, so they can ensure that the pertinent information about the antibiotics is available at the point of care. So why was the antibiotic started in the first place? And how long was it meant to be continued? What were the indications? What's the dose and what's the duration? You know, I don't come recently from a critical access hospital. I come from, you know, a more community-based hospital. But I will tell you, this was something that our pharmacists surveyed, and we were actually very shocked by how many nurses did not know when the antibiotic was started, how long that patient had been on it, and what the expected duration of those dosages were supposed to be. Would you have any comment on that, Dr. Stenyan? Do you see that too?
Yeah, I think that's probably pretty consistent across the board. You know, and really getting a sense of that duration is really important for the staff nurse, and that's really something that can be utilized for the staff nurse in terms of, you know, reflecting that back to the treating clinician in terms of a patient who's been on antibiotics for 10 days, 7 days, whatever it might be, to really say, hey, you know, do we have a stop date? When are we thinking if we're going to de-escalate this? I mean, just kind of planting that seed in the clinician's ears goes a long way.
Great. Well, and that information, that's going to increase your nurse's comfort level when they are asking for changes to therapy. You know, the other thing what we found in that survey was that sometimes they didn't ask because they didn't know when it had started, and they didn't want to be embarrassed by asking the doc when they really weren't sure when it had been started and why, and what the duration was meant to be. Next slide. So the second way that they can be of help is questioning the antibiotic route. And this is just an obvious one, to ask the doc if that can be changed to PO, if at all possible during rounds. And I know in critical access hospitals, you don't always have rounds. So, there may be other ways of doing that. And if anybody wants to comment on that, please feel free to unmute and give us how you do this. But, that really reduces that risk of infection due to having an IV catheter in place. Agreed, Dr. Stenyam?
Yeah, I mean, this is a little challenging in the critical access hospital, especially as lengths of stay are pretty short. This is not something that you'd probably do on hospital day 1. This is something you would really focus on doing as you get into hospital day 2 and day 3, especially as patients are improving. So fever is gone, they've met clinical stability. You're starting to think about discharge. This is a great time to say, hey, the patient's taking oral, has an oral diet, they're taking other oral medications. Can we convert this IV medication to oral, to help facilitate discharge? That was definitely on my list of, the nurses are the best people to assess the ability of the patient's oral intake. And, as physicians, we come in and we see the patient 5, 10, 15 minutes, maybe a day, and, we're not privy to that information if we don't ask. So this is a great opportunity for a nurse to say, hey, they're taking orals, taking other oral meds. Is there something we can do to convert to oral therapy from an antibiotic standpoint?
Anybody want to comment on how you do this in your facility? Jessica, how about you?
I'm having computer's problems today.
Okay, Jesse.
Looks like you're up and running now.
This is a multidisciplinary team. The nurses, you ask the questions, and then our pharmacist, Stephanie, is involved in doing a grid daily that we look at. Oh, I'm sorry, my camera's not working. I was holding up. Doing a grid daily that we look at, and so that the nurses know that, yeah, you can ask. And we have empowered our nurses a lot more than they used to be.
Great.
So if they want to ask a question, as long as it's not something, really weird, yeah, we encourage them.
Great. Anybody else? Okay, let's go on to the next slide. So the next way that's recommended is that they reassess the need for antibiotic therapy every 2 to 3 days. And Dr. Stone just referenced that it's not on day 1, it's, day 2 or day 3, and with your short stays, it's probably more day 2. This is a hard one probably for all of you, because I realize you don't get your cultures back sometimes by that second day, sometimes by the third day, and sometimes by discharge you don't have them in a critical access hospital because you're sending them out. But once they do know the results of the cultures, they can consult with the care team whether or not the therapy is needed. Is it effective for the particular bacteria that's grown? They can also advocate for those narrow spectrum therapies, clarify the duration of continued therapy, and monitor for toxic side effects. Make sure that those labs are ordered that should be ordered for certain antibiotics where they can affect particularly renal function or other things. Comments, Dr. Stenyam?
Yeah, I mean, this is really kind of where you could use an antibiotic timeout. That's essentially what Sarah's describing here, is that you take time at hospital day 2 or 3 or at discharge. Many times that is hospital day 2 or 3 in smaller facilities, and take a pause to say, what can we do with antibiotic therapy? Can we discontinue it? Can we switch from IV to orals? what's the appropriate duration. All of that can be kind of bundled into this time period at that facility. Timeouts are sometimes hard to implement, especially if in a facility where you don't have set rounds. But this is the time you do it, really, hospital day 2 or 3. This is really an opportunity for us to, or for you all to kind of clarify the antibiotic plan, and then be able to educate the patient to it as well. This monitoring toxic side effects is important, and somebody needs to have that conversation, whether it be pharmacy or nursing, about the possibility of diarrhea, the possibility of rash, what to do in those instances. This is a great opportunity for nursing to get engaged.
And I typed in the chat box, but if anybody wants to open their mic, how many of you are actually doing a timeout? That actually changed. This was one of the requirements. And in one of our other cohorts, Dr. Spivak and Dr. Stenium talked about the fact that that's not a requirement anymore. Do you want to kind of give an update on that, Dr. Stenium?
Yeah, so antibiotic timeouts have been, recommended by the CDC. They've been recommended by a number of kind of organizations for stewardship. The data on them in terms of actual changing in practice when a member of the antibiotic steward team is not involved is pretty minimal. And so in the bigger studies that we've seen in the literature, the effect of an antibiotic timeout done by somebody, whether it be a bedside nurse, whether it be one of the members of the treatment team, without the input of the stewardship team, has had pretty minimal impacts. But it has never been studied in the small critical access hospitals or smaller community hospitals. I do think it probably is a benefit, and what it does is it gets people thinking about antibiotics, especially at the time of discharge, and especially in your assessment of the duration of therapy. So it definitely is not a main focus, especially with kind of new guidelines that are forthcoming. But it definitely is something that can be incorporated easily into a stewardship program that has the potential of augmenting appropriateness.
So it sounds like you would still recommend.
Yeah, I mean, I think it's one of these things where you look at, what do you have the ability to do with your resources? And here is an opportunity of an intervention that takes zero resources. You already have nursing there. It's already, set up. It's just a matter of, incorporating this into clinical care. It doesn't cost anything. And so you have to adapt your stewardship program to the resources available to you. Here's an opportunity to have a nice intervention that is free of charge and can be done anywhere at any facility. So it's definitely something I would consider.
Questions, comments from anybody while we go to the next slide? Okay, so these are kind of obvious, but review the antibiotic therapy if C. diff develops. And I do realize they've changed the name and I didn't change it on the slides. So those of you who are infection preventionists, I apologize. But that antibiotic regimen should be discussed with the physician, as soon as if that patient develops a C. diff infection. And, are all of those antibiotics still needed? Can some of them be stopped? Do they still need them at all? And then the last one, of course, is the hardest. And
Hey, Sarah, can I just
jump
in on that number 4? This is an incredible opportunity for nurses as it surrounds C. diff. So what Sarah says is totally, absolutely right. That the time of C. diff diagnosis is a time for stewardship. And if somebody's been diagnosed with C. diff and they're on concomitant antibiotic therapy, the ability to treat C. diff and get symptomatic resolution is so hard. So if somebody has true C. diff and they're on Zosyn, you're not going to get anywhere with the C. diff until you stop the Zosyn or ceftriaxone or any other antibiotic. And so it really should be a component of the antibiotic stewardship program to really focus on patients that have C. diff, diagnosed with C. diff, and look for concomitant antibiotic therapy, proton pump inhibitors, any of those, that's a really great opportunity, whether it be for nursing or pharmacy, or if you have a clinical lead. One of the other areas that nursing has a really huge role is in terms of the diagnosis of C. diff. And this is something that we've been doing here with Intermountain Healthcare, and this is where we truly engage our bedside nurses. We know that the tests that we have for Clostridium difficile colitis are very, very sensitive. They pick up colonization, and they also pick up true infection. If you are going and testing everybody, you will pick up C. diff, just because we know that 10% of hospitalized patients have it in their gut, regardless of diarrhea. And so how we use our bedside nurse in C. diff is that if a clinician orders a C. diff test, we make sure that the patient truly has signs and symptoms of C. diff before that test is sent. And so our nurses actually have a little checklist that they go through to say, does the patient truly have diarrhea? Okay, have they had 3 or more unformed stools in the past 24 hours? Is the stool formed or unformed? If it's formed, we don't test it. If they don't have 3 or more liquid diarrheal stools, we don't test it. Doctors don't know anything about the stools of the patient. They just see or hear what the patients tell them. Nurses know this, and so we use them as our advocates. And so if a doctor orders it and they don't have appropriate stool counts or consistency, they don't submit the test, and it doesn't get run. If they do, then they also are enabled and empowered to look at, are there alternative causes of diarrhea? Over 50% of the people that have a test order for C. diff are also on concomitant laxatives, whether it be Dulcolax or lactulose or whatever it might be. And so then the nursing can then say, hey, listen, I just gave this patient lactulose. Of course they're going to have diarrhea. He doesn't or she doesn't have an elevated white count. They don't have abdominal pain. And they're empowered to say, I don't think we need to test. And so then you prevent another test. And so really using nursing to look at the appropriateness of C. diff testing is powerful and makes great impact in terms of your hospital onset C. diff rates. And that is really where something you could really have a great intervention. In smaller hospitals, it's going to be harder to show this just because your numbers are lower, but it doesn't make it any less important. So I think number 4 there is a really great opportunity.
Well, when they're tracking the 7, correct me if I'm wrong, when they're tracking their 7 elements, they can count that as an intervention, can't they?
For sure.
They can count that under action.
Yeah, that is definitely an action element. And what we call this now is called diagnostic stewardship. And so when you talk about C. diff, there's antibiotic stewardship, appropriate antibiotics, et cetera. There's infection prevention in terms of decreasing the spread of C. diff and C. diff spores. And then there's diagnostic stewardship, appropriately using diagnostics to detect C. diff, because much of our C. diff is just overdiagnosed and we're just picking up colonization.
So I'm betting the group is thinking this. Are you willing to share the nursing checklist?
Yeah, we can share that.
Great. Does anybody already have something like that in place? If you want to unmute or chat in, we'll give you a sec. Doesn't look like it, so that checklist would be of value, I'm sure, to all of them. Yeah, this last one, I'm just going to tell you, medication reconciliation, if we could get this to actually work, we would have a lot smoother care transitions, because I'm sure you see this too, and we've seen it in the work that we've done with care transitions, that this is really the #1 factor where we have something adverse occur and the patient come back to us as a readmission. So just remember, this is really, really a critical element. This is not something that should just happen on paper. This is something where there should be a nurse to nurse, a doc to doc. And I'm just mentioning that because sometimes that doesn't happen, and then we lose even the pieces that happened with nursing. So that care transition is really a critical element of protecting our patients when we're talking about antimicrobial stewardship. And I'd look to you, Dr. Stenham, for additional comment there.
Yeah, this is hard. And you're right, it's been attempted in many different iterations. But transitions in care for antibiotics is really critical, and you can do a lot in terms of just duration of therapy. Listen, I guess physicians are bad at math because, if you treat pneumonia for 7 days, many times physicians will treat them for 3 days in the hospital and then give them 7 more days on discharge. That equals 10 days, not 7. So there's easy things you can do at that care transition to really impact stewardship. That's one. And then critically important is, especially patients going out on intravenous antibiotics, that care transition is such an area fraught with medical errors and poor transition and poor communication. It's really making sure that handoff is done well and done seamlessly.
Anybody want to comment? I will tell you, as quality director, of all of the things we tracked within our quality program, I hated to see the numbers on this because this was one that we didn't have it down, and I will bet that most hospitals really struggle with this process. Next slide. So one of the things that you asked about when we did our original presentation, we asked you what you wanted to hear about. We asked you whether or not you had nursing education that was continuous on antimicrobial stewardship, and most of you said no. So what I did was I pulled a few websites, and all of these are free. They are things that your nurses can go in and just do this, so you don't have to build anything special. You can allow them to just go ahead and take these, and most of them actually do offer CEUs also. This one comes from one of the other QIOs, and it's focusing on colonization versus infection. And I did review this. It looked like a pretty good program. It's very focused primarily on long-term, but in a critical access. I know a lot of you do have swing beds, so you do have those patients for longer in a nursing home setting. So this might be one that you would want to look at. And I don't know, Dr. Stenu, if you've ever reviewed this site or if you ever have any comments on that one.
No.
Okay, next slide. These are modules that you can actually go in and take. And again, they offer CEUs to your nurses. They're relatively short. They're very precise programs. So like you have general guidelines for urine testing, SBAR use for skin and soft tissue, urinary infections, respiratory infections. All of these have short videos within them also that your nurses could take and go ahead and get the CEUs, and it could be your continuing education program without having to build anything additional. Next slide. And this one actually comes from AHRQ, and it's the Antimicrobial Stewardship Program, and it is specifically nursing education. It's relatively short. It's about 30 minutes long. And, that would be more of a beginning training or maybe an annual training for your nurses. And next slide. And then we also have one that we pulled that was empowering nurses from the CDC. And this is a pretty good program, but it is a little bit longer. It's about 55 minutes long, but it really does talk about how do you empower your nurses to be antimicrobial stewards at the unit level. Also talks about leadership getting involved in it. So it might be one that you want to have your directors and your leaders also take on an annual basis. And I see Elaine is putting some of these connections, some of the links into the chat box. We will also send out these slides so that you will have all of these links.
Yeah,
so,
and I was trying out these last two slides. You have the link there, and they say, sorry, this video is no longer available. So I'll research that and send out the correct links.
Okay, sorry, I actually just pulled them, so I'm surprised at that. But you know, we want to send you the correct link. So, you know, Elaine is always the one who makes sure that we do things right. Without her, we couldn't do this at all. And then, Dr. Steinium, do you have any other sites that you'd like to mention to them?
No, I think those are good. The HRQ site, I mean, they typically have really good material, as does the CDC. So I think those would probably be the two I'd go with.
Anything that y'all are using that you'd like to mention to the group? Okay, so y'all have been very quiet. So next slide. Remember that they're ideally positioned. We're going to send this article out to you that we used for this. It was really a good article, and you know, hopefully you can get some additional information out of it. Thank you so much for joining us.